Alrighty, Darren, thanks for coming. And you can take it away.
Good morning, everybody. My name is Darren Paskey, the Support Employment Program Manager with FCS. Um, Definitely, we're going through some changes right now. My coworker, Anessa, who's the Support Employment Program Manager for Housing, just accepted a new job within our team. So we are currently recruiting for supportive housing specialists on the west side, and hopefully we'll get approval for backfilling that position for the east side as well. I think Anessa will be doing double duty. So just a little bit of grace if you do have some questions in reaching out to her. She's fairly busy these days with a full to-do list. But I just wanted to share that information that we do have some changes coming up with that. I come with 30 years of experience in behavioral health and ran a supportive employment program and worked with FCS for quite a while, and definitely it has changed since that time. But if you do have some questions as I'm going through the slide deck, please unmute and ask your questions. I think it's always good to that from the beginning. And I think we have enough time too during this if you want me to stop and I could pivot to the FCS website and actually go through the sample employment assessment form. I can do that as well. So as we go through some of the information, and if you find that helpful, let me know and we can pivot from there. So here's some objectives for today, learning a little bit about FCS services, focusing on the principles of housing and principles of employment. Are you folks currently making referrals and completing the assessments and getting authorization from services from WellPoint? Or is this all brand new? Oh, it looks like you're muted, Yvonne.
Dang it, I thought I clicked it. I think this might be new for most, so I would start like very beginning.
Okay. So that might be helpful to kind of pivot and look at that assessment form so we can do that as we go through. So this is a little bit about what FCS is. It's part of a legislative process that started, I think, in 2011, and looking to make sure if we're going to fund these services that we're going to provide equity across the state in terms of services and contracting. So out of that came the process where the Healthcare Authority requested 1115 waiver from CMS Medicaid to be able to fund employment services and housing services in a fee-for-service model. So that's never been done before. Everything is usually grouped into different services, but this is really unique. And 1115 waivers are across the nation. Every state does things a little bit differently, but many of them do follow the model that Washington took, is to really look at how can we intentionally fund employment services and housing services as well. We recently got our 5-year extension, so the current extension runs through June 30th, 2028. Right now, we have almost 16,000 people enrolled in all the FCS services right now, with 559 service locations and 241 different providers. So if you ever go to the provider map, you can kind of see the different density in terms of Western, Eastern Washington and pockets. So we are going through a process right now to redetermine the process to add new contractors and kind of hopefully, provide a little bit more balance in terms of services that need more service providers for that. So a lot of the FCS services, and I always like to talk about social determinants of health because this is kind of a core piece of the services that we're working at. What are all those services that we provide that really provide that web of support for an individual making some transitions to be more independent, more autonomous in their community? And that also impacts, how you do your documentation for these services. all the services that we're talking about are going to be medical necessity in terms of what is the real reason why we're providing the services and how do you provide documentation. We're not going to cover documentation in this training. We do have some other things coming up, but I always think it's important to kind of weave those social determinants of health factors as we look at all those different supports and how they align to the different principles for housing and the dimensions for housing and principles for employment. So it's really, this is a medical benefit. And that's what we told CMS when we have the waiver. That's really going to focus on these two services. It's not an entitlement program. The funds go to the service provider. Those services go to the individual. It doesn't backfill any wages or stipends, and it does not pay for any support for housing, rent in the arrears, anything like that. We do have the Transitional Assistance Program, TAP, which has been very robust and demand is very high. Those funds again will open up on July 1st with the new contract. We've seen services demand very high. Dollars get exhausted fairly quickly. So if you're thinking about any kind of those resources that people might need, it's good to kind of have a strategy now to identify those people enrolled in FCS supportive housing and how those funds might support them in their housing transition or, maintaining their housing. WellPoint is our third-party administrator. The HCA decided to hire an administrative partner to provide some assistance in managing the network, helping providers with the referrals to services, organizing that information, also in terms of creating forms. The assessment form is now electronic online, so that's been very helpful. They also have a claims piece, to manage. Some organizations already have a clearinghouse for Medicaid that they can use, or they have a system called Availity, which is free to FCS agencies to use to help with the billing process and do those batch billings. We're also really focusing on that continuous quality improvement process. So we ask folks to be able to report data monthly and send that over to WellPoint to be able to collect and share that through the network. Right now, it's a pretty low percentage. So I always encourage folks to be part of this system is really to actually be able to use the tracking forms and provide updates to those outcomes, because we use those outcomes to advocate for our sustainability with our legislature so we can maintain funding coming up. It's all part of that sustainability plan. And again, we have the TAP, the Transitional Assistance Program, and now we've just added AHA, Apple Health and Homes, which is another way to transition people from homeless into housing through a lottery system to get vouchers. I think there's 6 months for different sites across Washington. So it's great to see with AHA that these are new capital projects that they're building new residences for folks to be able to meet the growing demand here in Washington State for housing needs.
Darren, can I ask a quick question?
Certainly.
Some of our partners are not completely medical, so some of these terms I just want to make sure people are on the same page. So WellPoint, to be clear, is one of the managed care organizations, correct? So that's the insurance provider, correct?
It, two hats, right?
And
Because when it comes in Medicaid, they could have that insurance through WellPoint, but they're also our third-party administrator.
and so does the client have to, in order to participate in FCS, does the client have to have WellPoint as their insurance?
Great question. No, the person can choose any number of the plans. I think there might be 5 plans in Washington. They can choose any one of those and take advantage of whatever benefits that those plans have, and you can still have Molina and still be part of our FCS community.
Okay, that's helpful. Thank you, Darren.
The big piece is that definitely use your provider one to check their eligibility, because without that, uh, nothing moves through the assessment process without that validation with the provider one. So part of the TPA activities. We do have a monthly Q&A. I encourage all providers to be a part of that because even if you don't have a question, you can hear all the other questions that are going on, and they give updates about data and trends and kind of see where the system at and how much it's been growing. So it's usually the last Wednesday of the month, I think at 10 a.m. for that. And if you want to be more involved, you can fill out an application to be part of the quarterly advisory council where we have folks from the HCA and the TPA, as well as our community partners as part of that. To always look at that sustainability and look at some of those challenges within maintaining the program and hopefully changes that will be coming up as well. So I said you have to have, active Apple Health. You have to be 16 years or older for both employment and housing side of the house, and also meet just some of the medical necessity and risk factors, some of the health needs, some of the risk factors that we'll kind of look at in a minute. But definitely, providers want your best friend. However you manage your system, definitely to have somebody checking that authorization prior to going through the actual assessment process. So when we talk about health needs, this is what we're really looking at, these pieces. Behavioral health, mental health, is there some kind of diagnostic piece? It could be clinical, or it could be just the person self-reporting, I have anxiety, I have depression. WellPoint may ask for some additional information for clarification, and as we'll look at the assessment form, there's some dialog boxes so that you can add some information as well. But sometimes, even if somebody might be moving through their behavioral health journey and have some stability, without the support you're going to provide, they could, look at uh, some things or deterioration of functioning. You can also use that as part of the framing for some of the services. Just as with SUD, do they have a diagnostics? Have they reported their own inpatient treatment or hospitalizations or maybe incarcerations because of some of their disorder, some of their activities? We also look at, some of the activities of daily living. This definitely aligns with some of the housing, and it could align well as well with employment. And definitely some of our partners through our ALTA programs, they just changed the name to HCLA. Haven't not used to that acronym yet for that piece for the DSHS services, but they definitely look at some of those daily living activities or those supports that might be needed so that they can maintain stability in the home. And they must also do a care assessment. That's something ALTA and WellPoint would have. That's not data that the HCA has for that. Or maybe the person is just self-reporting being homeless, and there's a self-reporting attestation that you can use to support that with housing. So it's a little bit different definition from the HUD definition. So again, FCS is really looking at that flexibility in ways that we can meet the person where they're at.
Karen, I have a question.
Mhm.
So for those of us that are not medical providers or don't have a provider one access, some of us are simply connecting with families in the community, folks in the community who have a need. How would those folks who are not a provider best help that person get connected with these resources if they're eligible? Where would we direct them to?
Um, I can pivot and we can go to the FCS site and look at the assessment form, but we can also look at the referral form. So we have the philosophy of a no wrong door where you could make a phone call to FCS and say, hey, I'm working with Darren. He's reporting some of these needs. I would really like him to be referred to FCS to one of the service providers. We can also take a look at the provider map so that we can kind of see where the provider's in location. One of the challenges that we face as this network grows and expands is that the map isn't like real-time data, as you'll see when we look at, I think I was just there the other day, the last update was April, and not all providers provide updated information, i.e. whether they accept external or internal And most providers work internal basis, so it does take more advocacy and case management pieces to find somebody who might be accepting those external referrals. I was just working with somebody and said, "Hey, Darren, I just called 6 people. I'm not getting phone calls." So there is that challenge. Not all providers are as responsive, but also that challenge whether they're taking those external providers or not. When I worked with the behavioral health organization, that's how our agency was. Like, unless the person was enrolled in all our behavioral services, they weren't able to access those services. But some providers do rely on those external referrals to build up their base. Is that helpful, Kelsey?
That is helpful just because we can try and help figure out if they're already connected with a provider who can then in turn help them access these services.
And,
Um,
and that provider should have provider one, you know.
yeah, I mean, yeah, so as long as they have Apple Health, we can look into how to connect them. At least if we're not connecting them directly into the FCS program services, we can connect them with a provider who might be able to help them, or we can try to.
Yeah, I track you with WellPoint. Diana.
Um, I have two questions. The first is if it's a couple and one of the pair qualifies,
Mhm.
can the other person live with them in the supported housing or do they have to split up?
I think it depends on what the housing site is and what the lease would say, and if it's a voucher, what the voucher would say. So, that partner wouldn't be able to receive direct services, but definitely when you work with an individual who has that support or significant other, sometimes you do have to kind of look at some of those challenges and then align whatever that end result for housing looks like. Both
The
people.
other part is if the client has a pet, um, does that disqualify them?
Not from our services, but again, it would be up to the landlord and how that looks and whether is it emotional support animal that maybe you could get some documentation from a PCP to support, or is it just a pet? So sometimes, there's those nuances that could be important that might help that discussion with the landlord.
All right, thank you.
Great questions. I see some stuff in the chat. I'm not able to kind of view that. So if there's definitely some things out there, Yvonne, please, stop me and I can address some of those.
You got it.
So this is just one. You only need one of these. So sometimes people see this list as like, oh my God, I don't have time to do all that. But all you do is need to focus on one for the assessment. And then again, looking at supportive housing risk factors. Again, we're looking at maybe that chronic homelessness. And this varies a little bit, from HUD, looking at those 12 months. Let me see if I can boost this just a little bit. That looks a little small. Looking at some of those guidelines to kind of how do you, document that chronic homelessness for folks, or within FCS, you can do the homeless attestation for that. Maybe they're having some institutional contacts and that could be incarceration, as well, is to be able to document those stays and also document how some of those stays can negatively impact somebody and why they would need support to reintegrate into their community. Or maybe there's some residential stays that somebody has and they're looking to kind of transition out of the more formal environment to a less formal environment for supports. And definitely caretaking and caregiving staffing is a huge challenge across the state. So definitely that could also impact and create that instability or risk for destabilization, having all those turnover and care providers. There's also a PRISM risk, which is something Alta or WellPoint would have access to. And that kind of looks at data that they are privy to and kind of looks at the utilization somebody might have. Like, are they going to the hospital every other week or once a month? Kind of all those additional encounters with an ED would increase your risk factor in the PRISM score. So that could also be a way to show that there's a need to change the behaviors, and we can do that through these FCS services.
Can I ask another clarifying question about health insurance? So, they're Medicaid eligible, they have Apple Health Insurance, but it's not WellPoint. And I know you said they don't have it. I'm looking at everything and it says Medicaid eligible. Where we live at in Washington State in the Port Angeles, Clallam County area, there's not a lot of providers who actually accept WellPoint. So would people who are eligible, do they have to switch their insurance to WellPoint?
That's a great question. And I was out in Port Angeles, working with Peninsula, and that's one thing they're saying is just like, we don't have a lot of providers. And I think it's really important to kind of look at, those, the formulary for medication, but also the list of benefits and who they are, because it is so hard to access those. So I think it does make sense to kind of look at those plans and kind of see which gives you the most benefits, because it might be really hard to find that provider who would accept, that Apple Health. But that wouldn't be a barrier to, receive the FCS services. Like, it just because it's more rural and kind of borders, I think, sometimes like Port Angeles and frontier issues, there aren't a lot of providers. And maybe, Peninsula might be the provider that you can use for the FCS services. I think there's some program in Bremerton actually works and comes out to Port Townsend. So some of it depends on that provider and how expansive they are for services. Sometimes providers have multiple contracts that allow them more flexibility to be in some of the more far-reaching communities that may not have ongoing support. Is that helpful?
It's a little bit helpful. I just know from personal experience, like with foster kids who had WellPoint, in order to get the care that we needed for them, we had to switch
Mm-hmm.
um, to a different provider within the Medicaid services.
Right.
So I'm just curious if people are eligible and they meet the eligibility requirements for the FCS services, but they're not a WellPoint.
And
They're
that's okay.
eligible- They're Medicaid eligible. They won't have to switch their insurance.
No, WellPoint just say administrator in this case, so you
Okay.
don't have to have that Medicaid provider to access these services.
Okay, great. Thank you.
Sure. Great questions. So we're going to switch and pivot over to employment a little bit, and we're kind of look at some of this very similar categories, again, the behavioral health, mental illness, SUD, particularly deterioration. And this could be deterioration, functioning level at a job, maybe functioning level at school. Maybe you have a history of somebody not being able to maintain employment because of the underlying diagnosis without some indirect support, or because of lack of support, there's that dysfunction in role. They're not able to maintain employment, not able to maintain a training program. They isolate more. Any of those kind of variables could really accentuate, those issues and add information to the dialogue box. I think it's always good to have some backup documentation if you're working with some of the different providers and have some of those oral ROIs, just because sometimes WellPoint will ask for more information or clarification. It's always good to have that ability to bring in some of that diagnostic criteria. And again, substance use treatment, or, kind of working on, their abstinence or sobriety or some of those supports or identifying those triggers, that negatively impact their life. And again, that care assessment, people utilizing EDs out in the community, WellPoint would have access to that information. Or if people are eligible for ABD or HEN, they're also going to be eligible for this because those programs look at ways to get people back into employment, and it's a good match for some of that. And then those programs also have some separate criteria about work incentives and how that impacts eligibility for those programs for that. So as I said, this is a really unique program. There's not another Medicaid program I know that's fee for service out there. When I worked in behavioral health, it started fee for service and then it went to managed care, and out of this 1115 waiver, we do have the direct services again. There's a significant difference between each side of the house for employment. You get about 120 units, which is about a 6-month authorization. And within that, that's about 30 hours, and it's billed in 15-minute increments for that at $27 per unit.
Is there a limit on the number of units people can use per day?
That's a great question, Kelsey. It depends. So we do have an exception to the rule that you're working with me and I currently have an authorization benefit and you're finding that I need a little bit more support, or maybe things are going really well and we're spending more time in the community job developing. And you go, oh my God, I only have 100 units left and it's only month 3. We could do an exception to the rule to ask a WellPoint for additional hours within that authorization unit, saying, hey, we're having some success. Darren's getting close. I'm going to need, 20 more units, to get me to the end. It would depend on the documentation that you provide and what the barriers are and what the needs are for WellPoint to authorize. I've seen them authorize from 10 to 20 hours, but it's up to that individual situation.
So that's for an extension.
Yeah, for exception to the rule to get additional units within that 6-month period.
And how about, so sometimes services take a really long, like this, connecting with someone to work through services like this can take a really long time. And I know in some other Medicaid eligible programs that we have, when we do this fee for service and bill unit pay, unit reimbursement, that there's a limit on, like we can use 6 units per day with that client. So that's essentially an hour and a half. And sometimes more is needed, but we just can't bill for that time. Do you know if it's limited the number of units that they can bill per client per day?
I haven't experienced that, but I would caution in terms of if I was, WellPoint and somebody showed me that they used up all the authorizations in the first month. To me, I would have to look at the documentation and kind of see what's going on.
Sure, of course.
You're doing direct service and not administrative functioning stuff. There would be some cases where you do have some intense, advocacy, or maybe some really intense collateral pieces. Maybe you're out there meeting with employers or meeting with landlords. That would count as long as you can craft that medical note to show what you're doing. So definitely, I think if there was that much utilization, I would say make sure you have the documentation, because definitely I've talked to some DCYF folks and working with kids who are coming out of, aging out of the foster care system, and they're looking for that 24-hour care 7 days a week. FCS is not designed that kind of intense services. It can be a bridge or, woven with some other funding sources, but I don't think for those high needs, it wouldn't be a long-term sustaining for that.
But collateral services are billable if it's crafted in there.
You have to have crafted in medical necessity, because I've seen some people like, I'll just use your name for example. You and I were doing job development. I'm going out to employers on your behalf, and I say I go to Target and see if they're hiring, and I bill 15 minutes, or maybe I bill 32 units. There's no medical necessity in that. It
Mhm.
doesn't show what the needs are of the person. It doesn't show anything about the challenges or deficits. It doesn't show anything about next steps. But because of the level of anxiety and, not able to leave your residence, we really need to go out into the community independently so I can talk to employers, finding out what the hiring needs are, finding out what the transferable skills are, maybe asking for an application. It's having some of those so that we could craft that. It's like, well, the reason why they're in FCS, they really need this kind of support and advocacy in the community because their cognitive function, executive function, high level of anxiety, they're not able to do that. But we can bridge that with collateral services and come and bring that information back to educate the person about the options. And they can kind of say, maybe this isn't what I want. Thank you for doing the research. Maybe this is what I want. Let's craft a resume and put it with the application and going online. Is
Great.
that
Thank you.
helpful?
That is helpful. And then one more question about reimbursement is
Mhm.
um, for providers who maybe aren't like a large healthcare system and don't have um, aren't working in like a central management system that does their billing, can they bill for reimbursement directly through the Provider One portal?
No.
Okay.
So that's a good question because that is a massive system that can do that. When people become providers with this, that's not part of the answer because I think their category is non-billable, so they're not using provider, but they can use their own internal system. Like when I worked at a large behavioral health system, they had a huge billing department and they just used their clearinghouse for Medicaid. That's where Availity comes in because we have some very boutique agencies who might have one or two people that are able to use Availity and send their documentation in. Just one important thing is like if you do a batch billing and you do it once a month or every 2 months, and four of those notes documentation are good and one is bad, it will block that whole batch. So I really encourage people to look at a weekly or bi-monthly system because one bad documentation can disrupt your whole batch in billing, which can be really devastating for some agencies out there. So it really depends. There's definitely a wide variety of providers and how their level of sophistication with electronic health records and billing systems are.
Great. Thank you. That was really helpful.
But the Availity is free. I will say that I haven't gone through the training, but there are some different things available for the vendors, and WellPoint has the staff to kind of do that support. They're very the billing end, HCA is definitely the training and questions end.
How do you spell the name of that software program?
Availity. We'll see it on the website. So we'll
Awesome.
have to see how I did in my spelling bee. I kind
Thank
of
you.
spelling. All right, Diana.
Would FCS be something that could be used by the parents of disabled kids who are aging out of being able to get uh, respite care?
Ooh, that's a great question.
And this would be kids who have multiple disabilities and are uh, don't have communication systems, basically unemployable, need 24-hour care.
Yeah, and I think that's the challenge because FCS is not designed for that level of care, and there's really um, no way for us to match that up because we're looking at how to changing their situation or maybe doing some research about that, but I just couldn't see that in a 24-hour cycle for that. I think there are some other Medicaid 2.0, which is the current Medicaid waiver on, has looked at adding some new things. There's some things for folks incarceration and reentry to really help those folks get Medicaid upon discharge. That's still in the works. And there was another process kind of looking, you know, for day centers. It's still in the works, so it hasn't come. And I think the challenge would be that for that parent to kind of get some of these support, they would have to be their own agency. So you would have to really find out from that provider of what their level of care and support could be. They could weave it into some stuff, but it's not designed for respite work, because we're really looking at that individual and looking at those next steps on changing their lives. Definitely sometimes that progression can be a couple of years. Definitely within FCS, some of the information I've seen, people stay on FCS for years, which is great. But we could tie that into different systems like the DDA system for support and DVR for long-term services as well.
All right, thank you.
And on the other side of the house, we look at supportive housing. It's a per diem rate, so it's a 1 day rate. If you spend 15 minutes with someone, you bill out that $112 a day. If you spent 4 hours with the person, again, you would have $112 a day. The nice thing about FCS, which kind of gets to your question, Diana, not definitely respite, but you could do support where if you have somebody who's an FCS staff and they come out, they could focus on housing because that's a long-term goal of the individual, is to have more autonomy and maybe move out. But you could also blend that with supportive employment services. Maybe one of the ways to support housing is to get a job and what that would look like for the person. Even though that might be the very long-term plan, short-term plan could be, let's do some of that research and kind of see what might be available out there for folks. So that's definitely a key element of employment and housing is the daily rate. So definitely we see folks utilizing those rates a little faster, because sometimes working with homeless or doing some homeless outreach can really be an intense cycle and people need a lot more support. So again, to get more authorizations of units, you would have to advocate for WellPoint for an exception to the rule to up those authorizations for that 6-month period to meet the needs of the individual, and definitely have that documentation available to kind of show those different supports, that level of functioning or level of dysfunctioning, and which would require more support for stability. Any questions or thoughts on the rates? And I think it's good to know as you're working providers, providers are getting reimbursed. One of the things I see that these services are actually underutilized. I think it's about 3.5 hours a month for the employment side for utilization. I think it's a little higher. It might be about 4 hours. Yeah, a month for housing. So people do have the capacity to provide the services. There is a little bit of disconnect for utilization for folks, and actually maximizing authorizations and maximizing their units to provide support for that. This is just a contact, slide, and definitely I can send you the slide out so you have some of the contact information. But there's 3 contract managers with WellPoint who work with all our 241 providers to provide support across Washington. And again, my experience has been if I call and email, they're very responsive, particularly on the phone. I'm always able to get somebody within a few minutes to answer some of my questions. So I definitely encourage providers to make friends with their contract managers. So I just think that makes a better business and better connections with the folks so they can get the support as the providers get the supports that they need. So I'm wondering, this might be a good time to pivot and look at the assessment form since we just looked at the health and the risk factors. I'm going to see if I can do this.
Darren, I think that would be a great idea. And I think the referral would be really great. Just to give you context on who's in the room. So most of these guys are our care coordinators for Olympic Connect. And so they provide care coordination for clients. And so what we've seen are folks that are needing support with housing. And how I see this overlapping is the care coordinator being able to connect someone who might need a little bit more intensive time with like specifically housing, connecting them to an FCS provider. And so I
Yes.
think that referral process will be really helpful. That way they could provide care coordination for their other needs and then connect them to FCS provider who could also help them with the housing need. Just so you like know why I'm connecting you with this group.
Well, it totally makes sense. You guys are all advocating with other providers to maximize the resources and support, and there
Correct.
might be, some ways to enhance. And I admire it because it takes braiding and
Mhm.
weaving and
Mhm.
whatever you can do to make sure you can do that network of support. So this is our provider map, as I don't know if you can see, April 2025. So it's not real time. But you can look at, by counties, and I can move this. It's a little funky and touchy. So um, you can kind of look at it. And I'm thinking, is this your range over here that you guys are working with on the peninsula? And
Yeah, so it's Kitsap, Jefferson, and Clallam. So I know when you hover, it kind of tells you the county. So Shelton's a little too low, so it's like a little bit up. Yeah, so we're Jefferson, and then we'll be Clallam, and then Kitsap's going to be a little bit to the right.
you guys go up here and to the islands?
No.
Okay. So as you see, like in Clallam, there's 9 providers. So if we just go Peninsula, in the More Right group, I saw them down in when I went camping on the coast. And Morningside, has some. So definitely it's limited in terms of where the providers you can be. But definitely I've worked with Peninsula. I've definitely with More Right Group and Morningside as well. Morningside does employment and housing now as well. So a lot of the providers do both sides of services, which can be really helpful. And I think it's always good, to have an Olympic Community Action Plans as well. So it would just take some advocacy to make sure, do they, provide the services that you're looking for and support. They should be able to, but I know depending on caseload size and how many staff, all programs have a tremendous staff turnover, so that also can impact that ability to make referrals and get those additional supports as well. So definitely, I just encourage, folks definitely put this on your desktop. It's always, I think, good to know where the folks are and kind of seeing, where they're providing different services and support for the community.
So to be clear, with this map, it shows you the providers, and you can select based off county. And then does it tell you if they're Oh, it does on the bottom. I was going to ask if it's telling you if they're providing services through housing or employment, but it looks like the icon color is how you
An
determine
icon.
that.
So yeah,
Okay.
so the More Right group does, do both. And then, just like Skookum. But I would always call, even if you say they're not accepting referrals, to call and double check.
Skookum isn't Skookum anymore. It's Tesla or
You're right. They just changed
yeah.
their name. So yeah, our map. You're more up to date, Diana, than our map is. That was a great detailed catch. Great program. I've known them Skookum for decades, so the new title hasn't doesn't come naturally right now. So I just wanted to show you that that's available. And when I send out the PowerPoint, it's, you can share my email because that's part of my, resources under my signature for that. So let me change gears and let me go to the WellPoint site. All right. So this is the WellPoint site that providers can go to, and it's got their contact information. Also has access to the provider manual, which has just been updated this year. So I encourage all providers to have that on their desktop to refer to because it gives a little bit more detailed about the services in the contract. We're going to go over some of those during the presentation today, but I think it's always good for people to come and be aware. And we have our new program, Apple Health and Home, which is another project, funded a lot by Commerce to build new units and provide vouchers for folks to end homelessness. And then we also have information, some marketing information, supporting documents during enrollment. We don't have an enrollment pause right now, so some of the information hasn't been updated. We had that last April, but then that ended in December. So for this year, we don't have a pause of enrolling folks right now. There is a nice quick reference guide that's available because it just kind of goes over again these health criteria and some of the examples. So definitely, I think it could be handy for you folks to kind of be aware of some of the risk factors and see how the individuals you're advocating for can line up for those services. So this is the referral form. Like we said, no wrong door that you can call up, you can fax this, you can email it. Just make sure you have the, person's ROI, but it's a one-page form to make the referral. One thing I would add is just, if there's a geographic location of where your participant is, to kind of look and see what agencies are in that area with the map so that you can kind of highlight some of that. And it might take some advocacy too, with, priming the pump so to speak, with the agency to make sure that, hey, there are some referrals out there because otherwise they might just look at a broader view of who is accepting external referrals, which may not be in the same geolocation, which could create some transportation barriers for folks to get that support. So we're going to dive in and look at what a provider does for the assessment form. There we go. So we're just going to say this is our initial assessment. And we're just going to use our buddy test. SD. Oh. And we'll just do this. Since you have to be 16 years or older, I'm going to have to go back in time and, do some math real quick. We'll go. And we're just going to say it's today. We're very efficient. We're doing the assessment the same day, and we're going to send it to WellPoint for that. So we'll give it to the crew here. Should the person be homeless or housed?
Homeless.
Okay.
We can't go easy.
No, well, what makes it easier because I don't have to have an address. So thank you. But we're just going to use HCA right now. It looks like I've used this before and it remembers my phone number. And we'll just call myself case manager today. So this is what's important because for making the actual assessment, the provider needs to have the individual's provider one number. If you don't provide this, the referral doesn't go through. So I have a secret code for this test. Oops. And I forgot it already. 2, 3, 4, 5, 6, 7, 8, 9. Ooh, let's see. Is the person going to be Indian or Alaska tribe?
Yes.
Okay. And any particular tribe that you
Um, for ease of spelling, you could just put lower Elwha.
perfect lower E L H.
WHA.
Okay. And will the person be a vet?
No.
Okay. So here we go on these complex needs. So we just need one for the health needs right now. So let me blow this up just a little bit. Oops.
Darren, can I pause you really quick?
Certainly.
For clarification, is this done by the FCS provider, or is this like Diane as a care coordinator? She said, I think this person would benefit from FCS. Is she doing this on behalf of someone, even though she's not contracted? Like, who's doing this?
No, it's the provider.
Okay,
Diana would be able to do that one-page form.
okay. So she
Just
sent in the referral, the provider received this referral, and now they're doing this assessment.
right. Once they get hooked up
Got it.
with a provider, that
Okay. Thank you.
the provider, the person may already be FCS eligible. Sometimes people have been enrolled in the past and they just kind of hang out there for a while. WellPoint has worked diligently to make sure there's no kind of ghost clients out there that are just eligible, not receiving services. It's definitely a struggle, within the system. This is just kind of taking a peek of what a provider needs to provide in terms of getting somebody eligible for FCS, particularly focusing on the health needs for that. So for this example, if somebody had a health needs, what are we going to use for somebody in this case?
What if they're on SSI? Would that be one of the qualifiers
It's a
under?
great question. It does come in a little bit later on employment, but it's not necessarily a qualifier for this.
Oh,
That disability might because maybe they have SSI, they're disabled because of the behavioral health. So that could help with
yeah.
making the case. But in this case, it's nice that it's not part of the health score, the risk needs right now. So we'll just give them SUD and behavioral health. And then we come to the risk factors. I'm kind of always a fan of dysfunction and full performance because I've worked with so many people who, if they don't have support, uh, things happen. And this is the dialogue box where they could add information. And maybe the provider would say, hey, I'm working with Olympic. You guys might have some information that could be essential in terms of putting some information here, make sure, with the ROIs, that you're able to share information. But you guys might have some information, that shows, the person, going through different systems, not being successful and needs those additional supports to maintain their role in school or work or just being part of their community. And this is where it comes in that we're going to say, yeah, they're interested in work, and all you do is have to go, the person is making that statement um, for that. And we can just say, well, they're looking for work because right now they're unemployed. And here it comes down to income source that we can say, yep, they're receiving SSI right now. And even with that, as a provider, we know that they're on SSI because something happened. There's some disability, some impairment that is the reason why they're eligible for those services right now. And if they're getting that services, they're probably in that category. And we just said they're not housed. And, we could say right now they're going in a shelter. And we'll just say the person has poor work history. A lot of folks do have a part for that, but the person's saying that, hey, I need some help right now. And we can just say that we're getting all our information, from the person. But from your providers, maybe they have some additional information that will help with the process. And hopefully they might have even other information that can be included to make the referral. There's also this one thing that looks at strengths based to see what the person is. And since they're saying they're looking for work, we're going to say they have some motivation. And right now they're flexible because they really don't like the situation they're in. We also look at some of the barriers, and then there's a dialogue box. I wish there was a dialogue box up here for the person's strengths just to make this more strength based. But maybe there's, some poor work history, and we're going to say transportation is a barrier as well. And here, looking at some different, maybe the person does have their social security card, but maybe that's the only thing they have, or they may not even have that in terms of that they've been homeless and losing some of those documents. And then we can also send in additional documentation if that's necessary. And again, that the provider can add, in the dialogue box, just to reinforce, some of the barriers and maybe some of the diagnostic criteria for that. And then the person signs it. This is the step before the final review process. Providers really need to go to the review and submit, and that's when they can print the form. So I really encourage people to print it out, put it in a PDF, save it in your system before you make the submission, because then you don't have access to the information anymore. So that's just kind of a view of what the provider needs to go through to get authorization for services. So definitely it takes a little bit of time. Hopefully they've already done an assessment where they kind of learn about the person. Both housing and employment have best practices to kind of use some formal assessment forms where they can fill in those forms to get things going. And then usually it takes 5 to 7 days after this is sent in and received by WellPoint to get an authorization. But the authorization will go to the back date to when the form was done. So that's the nice thing about that process. Yeah, Diana.
Uh, I briefly had a client who was homeless and had SUD and mental illness co-occurring.
Mhm.
And he said he didn't have his medical insurance card anymore, but he was sure he was on the system. If I was working with that now, would I try to find out what his state insurance card was
Yeah,
or
you
his
could
ID number
look at Apple.
before I send it to FCS or referral to FCS?
I think the provider should be able to figure that out because the FCS provider would have provider one. They could look into the system and see if they're currently have it, or they could see that maybe the Medicaid lapsed because during COVID, it was automatic. It's not automatic anymore. So we do see some people who might have, fallen off and might have to reapply. But the provider should be able to do that. So I don't think you would need to do that doing the one-page form that we have. I think you should just be able to, do the referral form.
Okay.
And maybe that would be a note that, hey, person lost their ID, because definitely WellPoint will check on it. So I don't think you need to do that action step. So that's kind of WellPoint side in that administration piece. We're going to kind of jump in to see what the services are that we're really focused on when we talk about FCS services. So for employment, we look at the pre and post for housing and for employment. So a lot of what we encourage providers to do is this discovery process, which is building that relationship with somebody and building up trust so you can really know what happens. I've seen people say, oh, I can do this in 20 minutes, Darren. I'll just check it off the box. Yeah, you could do a whole assessment in 20 minutes. But are you really learning about what the person's goals are? Are you really learning about maybe any trauma incidents? Do you really learn about, the person's support network, who they identify in the community? So we really encourage providers, take your time. You can use the billable units to start this relationship, work on completing the career profile, and hopefully getting to know what some of the goals are um, of the person. So we're really focused on both sides for employment and housing, really looking at the person-centered uh, goals so that we can create that treatment plan that really specifies some short-term and long-term goals. And maybe there's some things that I'm going to do as a job developer. Maybe the person's also going to do some things. So we could create a job search plan where different roles are identified that people can work with for that. And sometimes some people need some additional steps or customized or job carving. FCS provides that additional benefits. If you have a great relationship with an employer and maybe you can create a 12-hour-a-week job somewhere with an employer, that all fits within the foundational community supports. We also focus a lot on benefit education and counseling. As you mentioned, Diana, some people have Social Security, have SSI or SSDI, and some people don't really know what the difference is. So we really focus on benefit education, that providers use some of the resources we have on our websites and tools, or reach out to us so that people are aware when you have an earned income, things will change. People's food stamps can change. Medicaid could change. Vouchers could change whenever you add earned income into that story, so that just people are aware of some of those things, so they're not caught off guard. Like, Darren, why is my Social Security check cut in half? Well, Social Security does have some work incentives. After you make over $85, for every $2 you make, they take $1 out of your Social Security check and goes to zero. Good news is you can do the math on Excel sheet. You have more money coming in, and you can keep your Medicaid due to 1619B waiver. So there's some positives with that. And I think in the state of Washington, you can make up, I think it's $65,000 now, and maintain Medicaid through that system. So there's some great work incentives. But we don't want people to be caught off guard. We don't want significant others to be caught off guard, or families. I've worked with families who have, their children on SSI, and it's like, what are you doing talking about work, Darren? People go to work, they're going to change the Social Security check. We rely on that for our family. So sometimes there's internal family barriers to help people get back to work. And it does take some education and reinforcement to do that. We also talk about transportation, not a billable service. If you go to Medicaid, transportation is not part of the formulary. But if you're driving somebody, the provider's driving somebody to an appointment, and you're talking about interview skills or their anxiety, you could craft that into a note. So with the person and kind of focus on their, skills and abilities, you can craft a note about transportation. Just not, hey, I took Darren to the pharmacy to get his meds, came home. There's nothing employment or housing related to that. We always encourage providers to build their network, because I don't think you can just do this job alone. You're either working with businesses, community stakeholders, partners just like yourself, to really help people with different supports to be successful. Employment is also supportive of education. So if somebody just wants to go to school or get a training certificate, we could use FCS to support that as well. And there's a lot of collaboration. You can never do too much collaboration, I think, in terms of building a plan of support and weaving different resources and funding sources so people can be successful. Any questions on those?
I do.
Mm-hmm.
So I guess I'm a little bit unclear if FCS is like an organization that does case management to help people find housing, or are you guys like a voucher program? Are you providing like rental assistance? I guess I'm kind of confused on exactly what the role is here.
No, that's a great question, because, we started out as just supporting services so that we pay providers to provide these columnist services. So there's no vouchers for FCS to do. There's no, rental assistance. There's no stipends associated. FCS is just a reimbursement process to pay the agency to provide these interventions through face-to-face, encounters or collateral encounters as well. When we look at some of the other programs that we've added to expand, like TAP, Transitional Assistance Program, if somebody is eligible for FCS housing program, they could apply and request funding, maybe to pay a deposit, maybe they need a bed so that they could request services. It doesn't go to the individual. Again, it goes to a third party provide those services. TAP probably has, I think it's $2.5 million per year, and they divvied it up to half of that in the first part of the year and the second part of the year. So with this new fiscal year, it opens up July 1st. And I think the first time we launched TAP, funds were utilized in the first 30 days. It was an incredible demand for that. And then when we get to now, our newest program, in conjunction with Department of Commerce, it's AHA. So now we do have a voucher system in place. So yeah, we do have kind of multiple prongs, but if we just look at FCS Prime, it doesn't have those additional dollars, and the dollars do not go to the individual, only the service provider. When I send out this PowerPoint, I'll add some information about TAP and AHA. I think I got some PowerPoints for that. The new AHA is definitely a new program. I'm not really familiar with it, but I can always reach out to Anessa to add for some consultation. I'll add her when I CC in the email, because in her new role, she's going to be working more with that program, so she would have some more insight and information to share on that.
Darren, can I also add on to what you're saying on why I think it could be beneficial for folks to participate in FCS? Amy, to answer your question, I find this to be helpful for folks that need more intensive space because of all of the things that could qualify to help. So an example is someone who's seeking employment. Instead of you're a care coordinator and you could set a goal that says like you should build a resume, they could use their FCS case manager who could sit side by side and help them create a resume. And then they could help them interview prep, and they could look at employers with them and help them fill out applications and things like that. So for you as a care coordinator, you guys could set goals on like what would be helpful, and you could work hand in hand with that FCS provider who could do that like more intensive piece that you're like setting goals for, if that helps like connect the dots between how this could help with Olympic Connect folks and FCS. That's the through line I see. Or with housing, like they could help them understand rental agreements and help them when they find housing, they can walk through and like advocate for them to make sure the housing is like a livable space and they're not like moving into a slumlord apartment. And so that's stuff that's like a little bit out of your scope, but would be a really perfect fit for an FCS provider. That's what I remember from the
Yeah,
program, Darian?
that's
Yeah,
helpful.
exactly.
Yeah,
These could be some things to nudge somebody. It's just like, well, hey, I just heard Darren say that. How come you're not providing that service? Or maybe it's just having that ability to go out to a homeless encampment to start building that relationship. It's just like FCS allows you to do that. Are you guys doing that? You could prompt somebody and make some short-term, long-term goals with that.
no, this I could see this being beneficial for some clients. I just wanted to make sure I understood exactly what it was so that I refer the correct clients this way. The ones that would benefit from this service, which I definitely have somebody in particular that I think could. So thank you.
Absolutely. When I talk to agencies, a lot of new providers coming on, it's just like, well, you guys are already doing a lot of these things. My agency, not a lot of people got to do stuff out in the community. So FCS can be a driving force to get people out of their office to engage people where they're at, whether it's employment or for housing. So definitely it's unique, to be able to do that. And I know sometimes people don't do all these elements. and that's kind of up to the provider. But I think it's always good to kind of be aware of the whole spectrum of services because it's just like, I think you guys could do some of this, that might be able to help the person become more independent or just more safe. I thought I saw some. Oh, there's a hand. Okay, Erica. I thought I saw it go somewhere.
Thanks. How do you support veterans? And in a situation where a veteran doesn't have their DD 214 form, how would you be able to assist them navigating,
Ooh,
still getting services?
that's probably the toughest question of the day. It's a great question. The VA is complicated. And you, as a provider, if you're working with somebody as a provider, they can use some of the FCS services to do that because it takes a lot of correspondence, in my own personal experience, working with the VA, and a lot of patience. I think, but as you're developing that relationship and you're trying to get some of the information, I think provider could use this, at least for on the employment side right here, kind of building that rapport is just, and I think you can create a storyline for medical necessity is just like, well, Darren has PTSD dealing with the VA. Boy, if I could come in and provide some of that support to get information and kind of find out was it an honorable discharge? Was it not? Or maybe whatever advocacy that you're doing. I just know VA is complicated, but you can use some of these services to do that engagement for that provider to start doing those collaborations to find out more or get. They just have to craft it because it could be so easy. I called the VA and they said I had to do that. Well, that's administrative services. That's not a clinical note. You really got to bring in whatever that barrier is and make it person-centered. And I'm saying this because I do documentation training a lot with providers, and providers are not Medicaid institutions with CMS. A lot of people are getting into Medicaid for the first time, and it's a disconnect. And people do get audited and reviewed, and sometimes they're asked to give money back. So I always focus a lot on documentation and treatment plans because then if you have a good quality assurance process, you're less likely to have recoupment for Medicaid. But it's a struggle as a trainer we're having with our community. Some people do a great job, some people struggle. But I think there's that opportunity, but it would be very individualized. And that could be with DSHS. It could be with DVR because you could take that person who's a vet and refer them to DVR. DVR has a ton of turnover in VRCs, so you might have to work on building that relationship or doing a presentation at their staff meeting to share some information about that. That's what that provider would do. And some of that stuff would fit with FCS. The nice thing about FCS, DVR does short-term services. FCS provides that long-term connection, which DVR really likes. So that could be an additional selling point as somebody thinks about VR services. Well, this is short-term. They're going to help you get a job. But then over here, the provider is going to do that long-term services. So that's probably a good segue into post-employment services. Was that helpful, Erica?
I have
Yes.
a quick question, Darren.
Okay.
What does DBR stand for?
Division of Voc Rehab.
Okay, thank you.
Sure. And if you want to know more of that, I can connect you with somebody about VR too. But as we look at the post-employment side, sometimes getting a person a job is hard. As a job developer, it can be really, really hard. But then when they start a job, it can be really, really hard because sometimes they say, well, thank you, Darren, I got a job. I don't need you anymore. See ya. And then 30 days later, it's just like, what happened? Well, I got fired. Well, what happened? Things happen. People don't have good relationships with the coworker, with their supervisor. Maybe there's a disconnect. I've had people take things off the shelf, put them in the pocket, out the door they go, and they get terminated. So many things can happen. So really encourage folks to be able to build that relationship with their person and have a sort of engagement that there's providers like, oh, somebody got a job. I haven't seen them in a month. Well, that's not a sort of engagement. We really encourage people to have contact 3 days for best practices after they get a job weekly and then pull back gradually. Because sometimes people aren't aware of maybe some of the things they get asked for, particularly job accommodation. Sometimes the job accommodation might be around the bus schedule because the bus gets there way early or leaves before the last bus, and maybe there's some negotiation that has to take place. Or maybe somebody is on Social Security and they're really petrified of their benefits changing. I've talked to employers about let's change the work schedule a little bit so that you can stay under your SGA with SSDI and you can maintain full cash benefits while you're going back to work. Diana. Oh, you're muted.
Does a really good job working with individuals.
Oh, I'm sorry, Diana. Something happened where the volume just took a nosedive. Let me up my
Okay.
volume here.
Can you hear me now?
I can, yeah, perfect.
Okay, I know that Tesla, formerly known as Skookum, does a really good job working with uh, young adults who have aged out of DVR and who are on the spectrum,
Hmm. They do.
on the autism spectrum. Are the other providers that adept at working with people on the spectrum in their job coaching?
I just want to
Like,
say
does a state have like a way of certifying them or
you guys have some really tough, great questions
I
today.
used to be a special ed teacher, so I always wondered.
You're in the know. Yep. So, that's great. Thank you for that experience and providing people with education. It's definitely tough. And then kind of working with folks to get employment. So I would just say, yes, I love Skookum, Tesla, because they do a really, really good job. And I've worked with that staff and met them. And they've even expanded into some other programs and stuff. So this is going to be, if I'm rambling, stop me because we don't have a statewide system that says who's certified. I have been advocating to get that added to the provider map because sometimes we have families, sometimes we have providers, sometimes we have people who refer. Wouldn't it be great to know who's been through a fidelity review? How do they rate? The state of Oregon actually did that, where they would do quality assurance reviews, what we call fidelity reviews, to see how they adhere to the best practices. And that's where some of these things come from, best practices from the individual placement and support evidence-based practice model and agencies. So they would put their scores on their website so everybody would know that. In Washington, we don't have that level of sophistication, that we do not have a mandatory quality assurance process to rate. When I started this position, we did go out and do fidelity reviews and score people. So you would know how intentional are they to these different principles. There's 25 principles in all. We're only looking at about 8. And I think that would be a great value. So you know who is invested in quality assurance and what their score is. And then some people have done follow-up reviews and we'd see those scores right. So we don't have any information about that. And now due to some changes in priorities and funding, we don't even do, we used to incentivize fidelity reviews in teams where we'd go out and have other providers come in and share information. We're looking for volunteers to do that now. So it's not a very good quality assurance process. And so there's really no way to educate you or the public about how intentional people are. I would say Tesla, very intentional. Other programs, not as intentional. And I think that's the very hard thing. I would say hard. This is just Darren speaking. As you guys looking providers, how do you gauge that? How do you gauge that intentionality? Are they getting people jobs? Are they getting people homes? It's really hard to know without kind of a standardized piece that would help you. I would love to see something like that, but we don't have that right now. Any other questions? You guys are awesome. And you're asking the questions and you're hanging around too. So I really love that too. And then you're asking more. So that's great to have. So here's, the glimpse of those sustaining services for employment. It could include job coaching. And this is something a lot of providers don't do. Tesla does, but not a lot of programs do because it is something of specialized services. Uh, some people don't even go out to the community a lot. They rely on Indeed to do job development. And if you have somebody you're advocating for and you know they had needs, it would be great to know that the people are actually supporting them in the community, meeting those individual needs. It can be really hard to know. Not everybody has certified benefit planners. The HCA has really spent a lot of time and resources to get more people certified and educated around that. But it's an ongoing process. Out of 241 providers, maybe there's 40 across the state who are actually certified. But there's other places that people on Social Security can access to get that asset, and DVR, Division of Voc Rehab, is one as well. And sometimes it takes that financial literacy too. How do we educate people so they can increase their assets and have more fulfilled lives and more independent and autonomous out there? And ongoing follow-up supports will look differently for a lot of folks. You see agencies that people get a job and they don't have any contact with them, or they have contact in the first month, then it kind of evaporates. So it's really unfortunate, but I also know that being a housing specialist, employment specialist, you become a subject matter expert in that, and it's really hard for organizations to maintain that or not to have higher caseloads that pulls people in different ways. Because sometimes somebody will be an employment specialist and a housing specialist all in one. And it can be really hard to be a specialist when you're having multiple roles and multiple responsibilities. So this is the 8 principles that a lot of the information in FCS is built on. We're really focused on people who say they want to go to work. Let's honor that. Let's try to get them competitive employment. A lot of integration. You have to talk to treatment teams. You have to talk to providers. You have to talk to people. Sometimes that's housing. Sometimes it's medical staff. Maybe sometimes in medical staff, you need somebody who will support somebody going back to work, because not all medical providers are supportive of that. Or if somebody's a VA and they go to work, it can be really tricky with their benefits, and you have to really get that specialist for the VA side to know what's going to happen to their benefits. Will they lose their cash benefits? Those type of things. And we really talk about zero exclusion, that, if somebody says they want to go to work, let's address that and work with them now so that we can learn what their goals are and not make them say, oh, they have to come see Darren 3 times. We have to check their medical records to make sure they're taking their injection once a month, or maybe they haven't gone to enough SUD groups, so they're not ready. We don't want any kind of barriers. We just really want to honor that process to help them with employment. And I've talked a lot about benefit education. We talk about rapid job search. And again, that's that intentionality. If a provider says we're going to help them with employment or housing has something very similar. It's just like, we're going to do that. And for high fidelity, we want to see that in the first 30, 60 days. It doesn't mean you're going to get a job right away, but maybe they did the process, they built a resume, they've done some research, they're having this dialogue, and they're starting to go out and meet employers. That's kind of that rapid job search process. Systematic job development. We ask people to track data. It's all about, do you track employers? Do you track how often your staff are in the community meeting with employers? Do you track how often they're meeting the community with the job seeker? All those type of things. There's a lot of data elements for that. And the best practices says unlimited time supports. That doesn't happen. The IPS does not fund the services. They've created these goals, but with FCS, we can come close that people can get reauthorized for services as long as they need them. And Division of Voc Rehab kind of likes that aspect because they can do the short-term services and then look at some of the long-term services from FCS. So that was a lot about WellPoint, FCS employment. And I know we're running out of time. What time did we have scheduled for this?
We've got about 5 more minutes.
So I think there's a lot of stuff on housing, just like there was in employment, and we can kind of look at rescheduling. I can definitely send you this. And if you want to kind of look at a deeper dive, it'd be great to have Anessa here, to kind of do some of that because she's the subject matter expert on housing. So definitely on the housing side, there's these pre-tenancy supports that they have. I think you guys have mentioned some of the advocacy with landlords or being able to read a lease and what a lease is so that you're not in an inhabitable space. And then those sustaining services too, to kind of maybe work with landlords or, how do you, now that you have a house, do you know how, cook a nutritious meal without leaving the burner on all day, all those kind of little nuances in some of the ADLs. And then these are the different principles for housing, again, focusing on that choice integration, definitely rights of tenancy, how you access housing and separating that the provider, FCS provider, isn't also the landlord. That can get tricky sometimes, but I know what happens because some agencies do own their own property and are landlords as well, but it gets complicated with that. So that's kind of super too brief to give housing its due, so we can always look at scheduling a time down the road. Any final thoughts or questions?
What is IPS?
It's the evidence-based practice of individual placement and support, developed through Dartmouth and now part of, I think it's Cornell University now. So they do a lot of research and they're actually looking at, SUD populations, different young adult populations, youth and transition populations, and how that model helps people go back to work.
Well, I found this incredibly helpful. I'm really excited that we could record it because it's, content heavy, and I'm glad that we have a resource for folks to refer back to. And I would love, just to, clarify, I would love for you to send this PowerPoint out so folks can also, hear the recording and look at the visuals.
Absolutely.
But I really love the map that you shared. I think that would be really helpful. And then for folks who didn't have a chance to look at the chat, Kelsey Hamilton asked if this is in the resource directory and just wanted to share with you all that me and Lauren talked about this earlier this week of how we wanted to integrate it. Darren showed that really handy tool guide of what each agency is providing in each county. So me and Lauren are going to, just so you know what our next steps are, we're going to reach out to each provider and ask them if they only accept internal referrals or if they accept external referrals. So when we add it to the resource directory, you'll know what their process is. So we're going to try to clarify that before they're added to the C2C resource directory. And then it'll just take us a couple of weeks because we're going to divide and conquer to do that. But just wanted to share that out. But Darren, you've been super helpful and I really appreciate your time.
Under my signatures, there's the provider map, but there's also access to our pathways to employment and pathways to housing. So there's even more. If you get curious for resources, they're pretty
Nice.
heavily loaded.
Nice. I love it. Well, I'm going to go ahead and stop recording.